Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm speaking to Dr Adrian Hayter, who's the Royal College of GP's Medical Director of Clinical Policy and a GP in Windsor. We're talking about the RCGP's clinical priority for the next 3 years, preventive medicine. In this conversation, Adrian explains why the college has chosen to focus on prevention, some of the work it will be doing on this issue, and the role general practice has to play in preventing ill health. He also talks about how addressing health inequalities feeds into this work, the resources the college hopes to produce to support GPs in practice, and his previous role as NHS England's National Clinical Director for Older People and Personalised Care, and what that involved during the pandemic. I'm delighted to be joined on the podcast now by Dr Adrian Hayter, who's a GP partner in Windsor and the Medical Director for Clinical Policy at the Royal College of GPs. Adrian took on his role at the RCGP earlier this year, and before that he was NHS England's National Clinical Director for Older People and Personalised Care, a role he held from October 2019 to January this year. Thank you so much for coming on the podcast, Adrian.
Thank you for inviting me, Emma. Great to be here.
You're the Medical Director for Clinical Policy at the RCGP, which, as I mentioned, is a role you've taken on relatively recently. What exactly does that role involve?
It's really about, as we develop new technologies, new medicines, new ways of doing things, we convert that into day-to-day practice as clinicians. And clinical policy is that translation of the new technologies coming in and how it gets done in clinical practice to be able to support better outcomes for our patients. And as GPs, we're well aware of how innovation and new technologies and new treatments come in, and we're very used to making those changes happen. So in the 30 years that I've been a GP, I've noticed many changes, from people having heart attacks to having their medicines for thrombolysis, through medicines for stroke, and many similar interventions which kind of go on. And general practice is a key area for clinical policy to be implemented in the right way so that it can make the changes happen for patients and have better outcomes. So for me, it's a great, interesting area, and to work in the college is a fantastic opportunity.
Why did you actually want to take that role on? Was there anything particular you wanted to get out of it when you decided to do it?
What I believe in is being a GP is what I practice, and I really enjoy that patient contact, that population with my practice at Runnymede Medical Practice in Windsor. But I see ourselves as GPs as leaders also in terms of making bigger changes happen at larger population basis. So I've always kind of modeled my career on being kind of practicing general practice, which is fantastic and rewarding, but also being able to lead bigger changes. And for me, it's the definition of primary care, which is what the alma mater came up with in 1972, which is that improving health outcomes by living within the resources that are allocated to us and by delivering that first point of contact of care with patients. And for me, balancing that role as a GP makes both of those things happen. So for me, taking the role at the college was the opportunity to think about clinical policy, but in the wider context of general practice. And over the last 5 years before I came into this role, I was working with NHS England on clinical policy for older people and personalised care, as you quite rightly said. But I felt that I had the opportunity in this role to widen my experience and my opportunity for leadership to the whole of general practice. And I haven't really done a lot in terms of working with the college. And this was an opportunity in my career to spend a few years really kind of supporting the college. And, why not now in general practice when we are facing some of the toughest times that I've had in my career in general practice? And I think we all need to step up to support our profession and our clinical specialty of general practice. And I think doing that at the college is a great opportunity for me to help make some of those changes happen and to also value the work that we do as general practice.
One of the things I know you've been working on at the college is the college's clinical priority for the next 3 years, which is preventive medicine. Why has the RCGP chosen to focus on that topic in particular?
Yeah, so it's really great because I was given the opportunity to think about this as a clinical priority area when I came into the college in February. And in coming up with the preventive medicine priority, I spent some time speaking to our members And the clinical priority should be the gap that we see, which is not being met at the moment. And taking my own experiences and taking the experiences of the GPs who work with us and on clinical policy, in the current environment of general practice, we are concentrating on seeing patients and seeing the immediate problems that they have, which is really important. We're also aligned to some of the chronic diseases and the chronic management of those conditions that they suffer from, often in a very unifocal kind of way, rather than kind of looking across all the conditions. And our last clinical priority for the college was thinking about multimorbidity, which was thinking about all the conditions together, which I think we can obviously incorporate and do more on. Then, taking all of that into account, think about the gap we've got. Now, when I studied to be a GP and did my training, I was struck by the principal model of the Stott-Davis consultation model. And within that model, it was very simple. There were 4 quadrants to the consultation. And if you think the consultation is what GPs do all the time, and it's our way of actually making a difference to patients. And even in a short period of time, like a 7 or 10-minute consultation, we can make a big difference to the outcomes of that patient. So if you take the Stott-Davis model, there are 4 quadrants, and we do a lot in the first 2 quadrants, which is the presenting problem that the patients come into us with and the kind of past medical, the conditions and things that they are living with. But we forget the 2 other areas which are really important to the outcomes for those populations. And those 2 other areas are thinking about self-care and supporting patients to help and support themselves in a better way in the future. And then the other area is health promotion. And really that is around the prevention agenda, which is really important. And I think it's really interesting over this last year as we've started to develop this priority of preventive medicine. And because we chose preventive medicine because we are medics, and prevention can be very wide. And that's not to say that we shouldn't be working with others who might think about a wider prevention agenda, but preventive medicine is really what we should be doing as medics in the college. We felt that taking all the themes that our clinical advisors have been working on, that we need to think about this gap of preventive medicine. And I think there's a great opportunity to do that. And very interestingly enough, I think it has kind of come at the same time as we've got a new government. And as you know, one of the first things that Wes Streeting and others have been talking about is that prevention agenda. The unique thing that we have in general practice is that closeness to patients and the communities and the trust that we have with our patients to be able to have that conversation around preventive medicine that possibly no one else can have in the same way and with the same impact. For me, that's really important to be able to take that agenda forward in a clinical way so that we as a college can do that and actually benefit populations in the future.
So what exactly will the college be doing over the next couple of years to try and move this agenda forward?
One of the reasons why I felt that we wanted to build on the multimorbidity priority, which we had last year, was to think about how we would do this in a way that would really kind of create some change to happen. So there's no point in having a priority if you don't kind of make the change happen. So my feeling was that there were a number of steps that we needed to take to be able to help take this forward. The first thing was to get the agreement of the council. First of all, getting that endorsement of the council and getting really a kind of a unifying voice around this is the thing that we should be doing was the first step. The second step, I think, is to really kind of think about what evidence there is out there. In order to look at that properly, we need to do a proper evidence review on the things that are going to make the most impact and the things that GPs can do in this agenda, because we must be realistic around the things that general practitioners can do, and then the things that we can work with others in health systems, with NHS England, with the Department of Health, with other people to enable them to do it so that we can collectively make a big difference. But I think kind of taking the evidence base first is really important. And that's one of the things that we're going to be doing a kind of a rapid review on, and looking at the things that we can impact most. And I think that will be involving our grassroots members, but it will be also involving particular people with special interests in specific areas across the college, to take their opinion and think about kind of what evidence we've got out there will make a big difference. And then actually thinking about our partnerships, because realistically, we can do things as a college, but we really need to be able to influence and work with and engage with others. And I think that's really important. And you can see how important it is in terms of the work that Chris Whitty's been doing on smoking and influencing it at a political level. And I think it's great that we can align to some of those messages that might be going up to government, but we'll also be thinking about some of the other groups that might be able to support and help us on this journey. And so what we want to do is to create some of those partnerships, to be clear and focused about what we can do and what we can't do and what's not within our gift, and then get on and do some of those things in partnership with others, but sometimes just as a college. And if you think about it, as a college, we've got the opportunities right from the curriculum stage of kind of thinking about where GPs are coming into training, all the way through to influencing how we do clinical pathways of care to be able to deliver in a different way. Vaccination, for example, is a fantastic preventive medicine agenda. We know how important that was during the pandemic, and we have yet more to do in terms of vaccination. So there'll be particular big issue items which I think we can do more, and we can support others and our colleagues in general practice to work alongside us and also change the dial on some of these things.
I've seen some of the paper that you put together for the council meeting, and in that, the paper, the college talks about wanting to take what you call a life course approach to prevention. So you're talking about starting well, living well, ageing well, and dying well. Can you talk a little bit about that and why you think it's important to think about prevention in those sorts of terms?
You see, as a GP, I think we think in those terms all the time, because I can see someone in my practice who's a newborn baby in a postnatal clinic, and then I can see an older person who's living with frailty and who has specific complex needs, as the next patient. And then I can go out and do a palliative care visit and see someone who's dying the next stage. So that is our work. Our work is actually around the whole life course. And I really value having that opportunity, or GPs value that opportunity. I think the other important element of that life course approach is the work that Sir Michael Marmot has done in terms of thinking about that life course approach, but also thinking about the opportunities at different stages of life course to think about health inequalities. That's something that is a high priority already for the college. We're doing a lot of work on health inequalities, and we just held a health inequalities summit, which we did just before the election. But there's a lot of work going on, because this is the difference now that we have compared to when I came into general practice, is that we can target populations. We have much more health intelligence about the people who necessarily don't come to us, but who have the greatest need. And I think in preventive medicine terms, that's going to be really important around taking that health inequality agenda across the life course to be able to support those populations and be able to think about their health in a much targeted way, because we've got that information. As a GP, I think what I've come to recognize over the last few years is actually the importance of knowing our patients and knowing the whole population of our patients living in the practice. Every now and then I'm surprised by the person who comes in who's had a chronic disease or an illness or something, who hasn't had any contact with the practice. And what I know is that if we had intervened at an earlier stage, if we identified people or supported people in accessing our services at an earlier stage, we could have done something completely different to support them. So that population health approach, because we've got some of these tools now in general practice, because of all the rich data that we've got in general practice and across health systems in general, is a game changer in terms of that health inequalities agenda. We need to be able to be much more targeted, sometimes because we've got scarce resources to be able to deliver across to our populations, and we've got to direct the right professionals to the right person in our population at the right time. And I think that is a unique opportunity that we have now, which we didn't have 30 years ago when I became a GP.
General practice has changed beyond recognition in the last decade, let alone the last 30 years. And you're right, that access to all that information that people have now makes it a very different place. All this work you're going to be doing, what's going to come out of it at the end of it to sort of help GPs? Will there be things that come out of it to help GPs in their day-to-day practice?
So the first thing I think is that what we can do is prioritize the work that we do in the college to be able to take into account things which are related to preventive medicine. So sometimes we have to think about the pathways that will actually be thinking about preventive medicine. Now, we know some of those clinical pathways are coming upon us now. Obesity, for example, is one of those pathways where we really need to be considering what we do. And this is going to affect day-to-day general practice in terms of how we manage patients. And really, it's not just about the drug that we have or that we might have in the future. It's about the support that people have to live healthier lives in the longer term. And I hope that we can be developing resources, to go for that particular example, resources about nutrition, resources about exercise, as well as the clinical pathways, including some of the new innovations and drug treatments that might be available. And I think general practice will be a happier place if GPs can be doing that holistic kind of care with the right support and the right understanding that we're not going to be just delivering drugs to people just to cure all ills. So I feel that choosing those clinical pathways, working really hard with that, developing resources and recommendations around treating those and managing those pathways of care, which take into account a much wider perspective than necessarily a medicines only approach, will be what GPs want to do in the future. Now, there has to be a number of things to support that, i.e. the services that integrate with general practice and that work with general practice. It could be dietetics, it could be things that we're doing with social prescribing and health coaching. We've got a unique opportunity now that we are in that integrated era to be able to pull these services together. And I think general practice is the place to pull these services together to be able to deliver this kind of care for the future. And I'm hoping that we'd work with NHS England to be able to ensure that that can happen in a way that's sustainable. So for me, it's the clinical policy development, but also I think influencing others and bringing services around. Now, that's going to need a huge change because we are struggling, as you know, with the workforce. We haven't got the capacity in the future to deliver without a real investment in terms of general practitioners who are going to be leaders in this space. If there's any professional within the health system that can do this, it's general practitioners. And so I feel that we have to step into that space, but we also need a recognition from government, from the health secretary, all the way through to our local populations. That investment in general practice needs to happen. And also we need to be able to invest in how we work with others. So this is often neglected. How does my practice as a GP practice work with our community services who are often delivering to the same population of people? Are we geared up enough to deliver those services together in a timely way? Have we been given the support and the collaboration to be able to do that? Because without investing in our people, we're not going to get those changes to happen. So some of the steps that you quite rightly outline in terms of this clinical priority are dependent on that infrastructure that we need in general practice, which me and other colleagues are going to be pushing for that agenda to be met so that we can achieve what will be fit for the future.
The clinical priority, is it for all 4 UK countries or just for England?
No, the Royal College is across the UK, and actually we want to deliver this priority, and the College Council has representatives across those 4 nations. We've got 55,000 members, and some of those are international members as well. So I think it goes beyond actually the UK. And interestingly enough, I was in Singapore earlier this year. The same issues and problems are there in their systems. And when I met with the College of Family Medicine over in Singapore, they were really keen to kind of think about this work. So I think it goes beyond just the 4 nations even, because our membership is an international membership, and actually we've got the opportunity to share some of that information across internationally.
You touched on the fact we've obviously got a new government. The Health and Social Care Secretary, Wes Streeting, has talked about the importance of prevention and public health. What sort of measures do you think we need to see from governments on public health and prevention? Because people often talk about public health and prevention, but then when it actually comes to delivering it, it doesn't really happen because you can't see the results of it maybe within the 5-year span of a government. So what do you think we need from the new government to actually deliver a decent agenda on prevention?
Well, firstly, I think it's the recognition that it takes a long time. And I think I'm really conscious that the health secretary came out to be thinking about, he's called it a long-term plan. We've already had one long-term plan from an NHS England perspective, but the language there, and for me, that's heartening because I'm thinking about the demographic change that's happening, that we're in. And that demographic change means unless we start to invest in some of these things, which will take a bit of time to produce the results, we're always going to be firefighting. We're never going to be focused on the longer term things. I think the other thing that is important is that there are some things that government can change. And I think, the smoking thing is an example of that. And I think to do this seriously, there are some other opportunities around that. I also think that we need to then work across different organisations. I'm sitting here in the Royal College of General Practice, but there are public health organisations who have responsibilities at a local town and council level who I think there are some great opportunities to be thinking about that. And I think if I think about it in terms of my own area, there are leisure services who are not necessarily meeting the needs of a health inequalities agenda around prevention and promotion of exercise and good health. So I think this actually goes to government to think about things not just in a very tiny focus, just health, if you like, but it's the wider determinants of health, which we all know are important. So I would be pushing that the government takes that approach to thinking about what happens at a local council level, as well as what's happening in the GP practices. And actually, what I do know is that when we come together as kind of local services and general practice, there's a synergistic effect. There's a more than the effect of the two sums that will actually benefit the population. And I think for me, that's the exciting thing. If we can start thinking about the integration of some of these services, and we've got that opportunity at an integrated care level to be able to do that. But what we do need is the commitment of local authorities and councils in the situation that they're in to be able to partner and make changes happen. Because the other thing is genomics and actually kind of thinking about the opportunities around genomics in terms of thinking about how we work. And, there are national programs around that. And I think there's some opportunities around that for making sure that we direct the right people to the right place.
Will that be part of what you're looking at as well? The understanding of how genes affect our outcomes and stuff. Is that going to be part of what the college is looking at?
Absolutely. And we've got some real expertise in the college, and we'll be definitely tapping into some of that because this is so important in terms of how we can set this out over the next 3 years. So absolutely, yes, some of those groups that we've got within the college will be really pivotal in supporting this piece of work.
I was just going to ask you a couple of questions about your previous job as well. I mentioned earlier that you were NHS England's National Clinical Director for Older People. What were you actually doing in that role?
I was fortunate because the long-term plan had already been supported and had just come out. Within the long-term plan, there was a specific program around aging well. And within that, there were some real programs which were there to be developed. So I was responsible for rolling out those three programs. The first was the urgent community response, which is actually really where community services get to people in their own homes within 2 hours. The second was enhanced health in care homes. And then finally, to develop a program called Proactive Care, which is around intervening earlier, identifying people and doing some case management and care and support planning around those individuals, which I launched just before I left the job. Then we had COVID, obviously, in there. And obviously, that was something I didn't expect. But I had to really support a number of things. Firstly, was the care home population. And you might remember they were the first big population who were severely affected by COVID. And so it was really rapid policy development. But the thing I learned was working with social care colleagues was so important, and people delivering care to be able to make that policy work, and the changes that were going about around infection control measures and other things. And then I developed the vaccination program for care homes. And you might remember the care home residents were the first group in the priority group for vaccination. And I worked with a number of colleagues and Nikki Kanani to design the process for vaccination of care home residents. And we rolled that out. We did a quick test in 2020 with about 7 sites across the country. And then we rolled that program out, and that's successfully being rolled out as part of the vaccination program up to now. And then the third thing that I did was there was an opportunity to think about care in a different way, which was thinking around how people might be supported in their own homes with acute level care. So this came out of sometimes the work that went on with the COVID virtual wards, where people were discharged home from hospital with COVID. And there was a particular piece of evidence called Hospital at Home, which the NIHR had produced, which I had sight of, which was a 3-year randomized controlled trial, which showed that older people who were treated in their own homes with acute level care, this means kind of care which normally would have been received in hospital, had as good outcomes and probably, if not better outcomes, by being treated in their own homes. And we knew that because lots of older people didn't want, during the pandemic, to go into hospital for reasonable concerns. And so I was able to be part of a team who supported the production of the virtual ward program, which we did some modelling on and got £450 million government funding to support hospital at home in every part of England. And for me, that was a really good way of seeing a whole policy area through, right from the beginning through to the implementation at the end. And so I felt towards the end of last year that I'd probably done as much as I could in the NHS England space for older people. And it was time to hand over the reins to another person. And I was the first GP actually to be in that role as National Clinical Director for Older People. It really was a great opportunity for me to put a stamp on that role as a GP. The person who took over from me is a geriatrician, Tom Downs, who's carrying on some of that policy work in NHS England.
There's probably a whole podcast in virtual wards itself. But I was going to ask you, just basically based on that experience of working in that role, obviously one of the challenges the NHS is going to have to face is dealing with an ageing population, with many more of us living a lot longer, likely with multiple health conditions. How do you think the NHS needs to change to deal with it? And what role do you think general practice has to play in all of that?
I think we're central to that role around an older patient population. I think there's a couple of things which are really important to that and which I feel are important, and I think it's well recognised. Continuity and that trust that we have due to continuity is really important. And for me, that is kind of one of the key foundations to being able to deliver. So continuity is important. And there are different ways of obviously developing that continuity. Also, I think, so for older people, it's really working as a team, which is really important. It's not just one person's skill that makes the difference. It's actually how we work closely as a team. That's whether you're in hospital or out of hospital. And for me, the opportunities that general practice have is that we can work with many, many teams. We are used to doing that, and we do that on a regular basis. So for me, working with those teams is so important. And I think those skills that we have around that MDT working as GPs will really pay dividends. That, together with the knowledge of the patient, allows us to support that older population in a better way. The thing that I think is difficult is that we have segmented ways of kind of dealing with care, and we have to rise to some of those challenges. And I'll just give one example of that. Dementia care, for example, is delivered at the moment in a way that is quite fragmented, if you like, because we have older age psychiatrists who support some of the diagnosis and some of the kind of interventions around dementia care. We've got GPs who kind of obviously are living with supporting and managing some of that long-term care. And dementia often comes with different conditions as well, so it's not on its own. And you've also got carers who are looking after people with dementia, so it's about a carer's agenda. So there's a very much holistic approach around managing that within a community, which is really important for general practice. But we've got new treatments which currently we know are coming up for Alzheimer's disease, which are a small percentage of people living with dementia who really kind of some of the skills and knowledge and expertise is through neurology. And neurology services in England are at breaking point often. And to be able to deliver neurology services to people with dementia and working across with older age psychiatrists and with the population needs a much more holistic response. So looking forward to our growing population of people living older, but also living with conditions like dementia and many others, we have a fragmented system which is not going to be able to meet their needs. And I think we have to be able to really think about that, and think about that at a local but also a national level, to understand if some of these treatments are going to be available, how are they going to be implemented, what role specialists have. And I think we can only do this by working really collaboratively and having very great skills at working across organisations and across specialties. And for me, there's a coordinating role that general practice has within that space. So that's just an example, I think, of the complexity that we're going to be dealing with in the future with an ageing population and with the resources that we've got currently.
That's the big problem, isn't it? Resources in the NHS at the moment, really, to deal with things like that.
And social care as well.
Absolutely.
I know that a lot of my patients are supported to stay in the community, live in the community, because they've got support from social care and also carers who are non-paid, unpaid carers. So it's a whole system response. But as general practice, we are in the middle of that. And there is no one better than your general practitioner or your GP surgery to be able to help support that. We just need to be given the opportunity and the resources to work with others to do that.
The government is talking about trying to increase the share of NHS funding going to general practice. With the way it talks about it seems quite serious. And obviously, I think with an eye to some of those things that you're talking about there, but obviously it remains to be seen exactly how that's going to work and how it will all shake out.
General practice is a great place to work. You can see from me, I'm still enthusiastic about general practice, but I do know that, people are finding it really difficult in general practice. I recognize some of my colleagues who are coming to my age can't wait to the day that they retire. And that's really sad, actually. It makes me sad. So we need to reinvigorate that. And, in the words behind me of the college, which is that science with compassion. And I think we've got that, and we've got the ability to lead as a college in some of the conversations, the science with the compassion, to be able to deliver across this agenda.
Brilliant. That's lovely, Adrian. Thank you so much for taking the time to talk to me today, Adrian.
It was my pleasure, Emma, at any time.
Well, that's it for this week. Thanks so much for listening, and thanks again to Adrian for taking the time to talk with me. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a range of other resources to support you in your role on our website at GPonline.com.